Up, brothers? Welcome to the third episode of Gear Growth and Gains. All right, so this week we are going to talk about 4 sections. First section will be about androgens and strength power. Okay, for making weight and for untested powerlifters. Okay, this will be non-hypertrophy applications. Second section will be the biological harms of AAS. Okay, what we know, what we don't know. There's a lot more we don't than do. We'll have 2 subsections, cardiovascular harms and psychological harms. The second section in particular, psychological harms. There's a lot we don't know. Okay. Third section will be female issues, the Secretagogues versus recombinant growth hormone, RhGH. And the fourth section will be thyroid function a la AAS and RhGH. All right, so let's get into the first section. So first section is about AAS and strength power, non-hypertrophy objectives. It's basically going to be a kind of discussion of the benefits of AAS without reference to hypertrophy. All right, so there are 4 subsections here. So the first that we will discuss will be the increased strength and power by androgen. Second subsection will be anticatabolism and anti-fat mass effects. Third section will be enhanced bone and soft tissue metabolism. The fourth subsection will be increased glycogen synthetase activity. All right, so first let's get into that strength, okay, benefit, power, benefit. So first thing we should understand is that strength and power are related. Power is a function of force divided by time. Strength is basically force output. So you can enhance power by decreasing the amount of time that it takes to complete a contraction or increasing the force that is output in a contraction or strength. Androgens work on both the numerator and the denominator, the power equation. So let's talk about how. First, in order to discuss this, we should discuss and review how androgens exert their effects. Okay, so androgens exert their effects. Everybody is probably mostly familiar with the classic genomic binding to the AR, which is a ligand-inducible transcription factor, dimerization, translocation to the nucleus, where androgens and AR bind to androgen response elements, AREs, in DNA to modulate transcription of target genes. This is what we call protein synthesis. This takes, weeks to begin after beginning a course of androgen. It's probably about 3 weeks to start noticing significant protein synthesis effects. Okay, so that's the classical genomic binding to the AR pathway. The other pathways are tethering to other transcription factors, for example, MEF2, SRF. Okay, this is done on chromatin of myoblasts. Okay, there is also engaging signal transduction pathways. This is, androgen basically via PI3K, AKT, and IGF-1. This includes activation of protein kinases, for example, beta-catenin. This would be downstream of SHBG receptor and G protein couple receptors. These modulate cellular responses to androgens. Okay, and the final way is cell surface membrane-bound receptors, for example, MAR, membrane AR. Okay, there's osteocalcin, there's GPCR6A. These typically modulate calcium ion uptake. Calcium ion Ca2+, you might see, is principally responsible for muscle contraction, but it also modulates signaling pathways like this. So besides the classical genomic pathway, these are all rapid, effects. If you were to think about how androgens work, right, they have direct effects. These are like proliferation, differentiation, protein synthesis. These effects occur by action on satellite cells, the myonuclei and motor neurons. I won't get too into depth with that. That might be the topic of the next symposium, though. I think in the next symposium, I will discuss all of these mechanisms of androgens in depth. All right, but let's go back to how T enhances strength and power, androgens enhance strength and power. So within days, androgens increase the excitability of the neuromuscular system, leading to predominantly fast twitch fiber recruitment. And there's a significant correlation between both total testosterone and DHT with median frequency content and muscle fiber conduction velocity during voluntary contractions. In men, a short-term E deprivation, which is far too rapid and sufficient in its time course to affect genomic pathways. Like I said, take like 3 weeks. Okay. This depresses the central neural drive to the muscle, a hypogonadism thing. Yeah. So these non-genomic effects encompass, at least in part, voltage-dependent potassium ion currents, calcium ion channels, and neurotransmitters like dopamine, which is principally involved in muscle contraction. Androgens thereby influence the nervous components of the neuromuscular system, for example, motor behavior, neuronal activity, intracellular signaling. Androgens increase cortical and spinal cellular excitability by decreasing neuronal excitation thresholds. The theory is that androgens function via non-genomic pathways in neuromuscular functions like strength, and probably only as an integrated step also on muscle size or structure. While androgen genomic pathways, remember, take about 3 weeks, are involved in long-term muscle structure and function homeostasis. DHT treatment of muscle fibers increases both twitch and tetanic contraction in fast twitch fibers. So these are like maximal voluntary contractions. These changes were accompanied by an increased MAPK ERK phosphorylation. These effects were abolished by an inhibitor of epidermal growth factor. After around 3 weeks, the genomic effects binding to the AR, homodimer formation, translocation to the nucleus, and affecting protein synthesis and translation. Predominantly, androgens increase muscle strength and power, but not fatigability or specific tension. Motor neurons express AR, and activation of these increases both motor neuron AR number and motor neuron number itself and their size. Okay, so you can see how these things would enhance making weight without increasing scale weight, body weight. Okay. Anticatabolism and antiadipogenic effects. This will be the next subsection of how androgens can be used to enhance strength and power without increasing muscle size. So, androgens decrease muscle protein breakdown during cutting, right? And they commit pluripotent precursor cells, which are like pre-fat cells, to a myogenic, meaning muscle, rather than adipogenic, meaning fat cell lineage. Fat mass regulation by androgens inhibits lipid accumulation in adipocytes, fat cells. Okay? It does this by downregulating several factors. Some of those are PPAR gamma, CCAT, enhancer binding protein alpha, leptin. Okay? It also reduces the extent of oil droplets, decreases the incorporation of fatty acids into triglyceride, downregulates acetyl-CoA carboxylase expression, stimulating lipolysis by increasing cyclic AMP activity in fat cells. The sum of androgen effects on fat mass are the combined effects of decreased differentiation of fat cell precursors, increased lipolysis, and decreased lipid accumulation. I should mention that Anavar has a unique hepatic ketogenic mechanism. Will be discussed in the forthcoming Meso article that I am writing about its unique effects. Okay, let's talk next about the enhancement by androgens, okay, within the context of aiding untested powerlifters for enhancing strength and power while making weight. Okay, so this third subsection will be about effects on soft tissues like bone, tendons, and ligaments. Testosterone at a dose of 250 milligrams weekly modestly increases type 1 collagen markers and type 3 collagen markers. So type 1 collagen is a marker for bone metabolism. And type 3 is a marker of tendon and ligament soft tissue metabolism. Okay? So the combined effect of testosterone on type 1 and type 3 collagen is an effect of dual mediation via aromatization to E2 okay, and ER-mediated effects, as well as via direct AR-mediated effects. I will point you guys to my anabolic steroids and growth hormone, their impact on bones, tendons, ligaments, and joints article on Meso. I'll provide a link to that in the show synopsis. It discusses beyond testosterone as here, as well, oxandrolone, nandrolone, DECA-NPP, and RhGH. Okay, so that is the third subsection. Now let's talk about the fourth subsection, and this is within the context of how androgens enhance strength and power without increasing muscle size for untested powerlifters that need to make weight. Glycogen synthetase activity is increased by androgens. This results in enhanced tissue level insulin sensitivity and fuel substrate availability for anaerobic bouts like muscular work, bodybuilding. Glycogenolysis catabolizes muscle glycogen stores, while we're working hard in the gym. Understand that 1 gram of glycogen stored pulls in 3 grams of water, which promotes muscular strength by mechanical means and anabolic signaling via cell stretching and muscle protein synthesis. Water is an integral component to muscle protein synthesis. If you're terribly dehydrated, you won't build much muscle. So yeah, glycogen synthetase activities being increased by androgen benefits all of those aspects. Performance for strength and power. Okay, so that's the conclusion of the first section. So let's get into the second section, which will be biological harms of AAS, and this is going to be curated to just discuss briefly in a lay format cardiovascular harms and psychological harms of AAS. Okay, so let's talk first about cardiovascular harms. So cardiovascular harms of AAS, we're dealing with dyslipidemia, we're dealing with left ventricular hypertrophy and left diastolic dysfunction. So with dyslipidemia, the primary mechanism by which AAS cause it is by decreasing HDL-C. This occurs by increased hepatic triglyceride lipase activity, HTGLA. What that does, lipase means breakdown, okay? So what that does is it basically breaks down our larger lipoproteins into smaller, more atherosclerotic ones. So rather than abundant HDL-C, we start looking at more abundant VLDL, or very low density lipoproteins. Beyond the dyslipidemic effects of AAS, we also have to talk about hemodynamic changes. Let's talk about that first. So with hemodynamic changes, androgens increase stroke index, right, which is basically the blood volume ejected by the left ventricle. This enhances or increases, I shouldn't say makes better, it increases blood pressure. Okay? But what you have to understand is that pressure overload and blood pressure, controlling these side effects with drugs like ARBs and ACE inhibitors, beta blockers for heart rate, is not going to protect you from the left ventricular hypertrophy that androgens cause. This is because androgens cause direct hypertrophy of smooth cardiac cells, just as it causes direct hypertrophy of skeletal, striated skeletal muscle cells. Just dose and time. Okay? This is why it's very important for people to get an annual echocardiogram. Okay, this is like a transesophageal echocardiogram, or echo. Okay, it's not to be confused with an EKG. It would be beneficial to do this with your doctor. Okay, a lot of times guys that have these done would be experiencing, regurgitation, mitral valve regurgitation. They would probably report to their doctor, I'm finding myself really tired, my heart's racing when I'm lying down, or when I just go for a brisk walk, I lose my breath. I feel like out of breath, my heart's racing. Those kinds of symptoms would be a reason that a doctor might order an echo. Okay, let's talk about the psychological harms of AAS. So there are definitely psychological harms of AAS, but there's a lot that we don't know. In fact, I would characterize it as 98% of it is unknown, and maybe 2% of it is something that we understand. The psychological harms of AAS. We do know that AAS decrease visuospatial learning and memory, and they are associated with personality disorders, especially narcissistic and antisocial personality disorders. They're associated with cyclothymia, which is a rapid manic depressive cycling. It's kind of like an acute bipolar syndrome. That's all we really know. Besides that, we do know that, androlone decreases dopamine. We know that it increases serum homovanillic acid that reflects increased net protein breakdown or net dopamine breakdown. So that's really it. That's kind of like my curated lay section on the biological harms of AAS with respect to cardiovascular and psych harms. All right, so let's move on to the third section. Okay, this is going to be about the female uses of GH secretagogues versus RhGH. The GH secretagogues, there are two classes. There's the GHRP mimetics. These are GH releasing peptides or GHRPs. These are essentially growth hormone secretagogue receptor agonists, GHSR agonists. For example, Ipamorelin and Ibutamoren, which is MK677. Those are the GH mimetics or GHRPs. The second class are the GH releasing hormone analogs, or the GH releasing hormones, GHRHs. These are essentially GHRH receptor agonists, and for example, include MODGRF1 to 29, which is otherwise known as CJC 1295 with no DAC. These combine synergistically to increase GH area under the curve, and they do so with the GHRPs like Ibutamoren, Ipamorelin, increasing GH pulse amplitude. Okay. And the GHRHs, like MODGRF1 to 29, increase the frequency of GH pulses. Okay, so the two combined synergistically are greater than additively. So GHRH, let's talk about this actually first now within the context of how they come in for women. So GH for women is not a very economical option. This is because women, when they're walking around, have at least 1.5 times, at least 50% more GH than their size matched male counterpart, if not more than 3 times as much. Women are walking around with way higher GH levels. Okay, a lot of this is related to the fact that estrogens increase IGF binding protein 1. This decreases IGF-1, okay, bioactivity. So it decreases and it does this in the liver. Okay, so basically the liver somatotrophs are what secrete IGF-1 in response to GH. Okay, so if you just take more GH, women already have 3 times as much as we do per body mass. I should say really per body surface area. So let's talk about how the secretagogues are more economical and more potent for women than for men. All right, so GHRHs, for example, arginine or MODGRF1 to 29. These increase GHRH. GHRH is something that's secreted endogenously to promote GH synthesis and secretion. And estrogen enhances the pituitary sensitivity to GHRH. For example, MODGRF1 to 29. Okay. GHRPs, E2 supplementation, actually potentiates the stimulatory effect of the dose by 1.8-fold. The putative mechanism for this is that estrogen increases the GHSR number, or the number of growth hormone secretagogue receptors, okay, which are the target of the GHRPs. Really, to summarize, for women, whereas exogenous, recombinant RhGH increases blood GH, with women's increased estrogen levels, its efficacy is blunted by a diminished increase to IGF-BP3. Now, we actually want increased IGF-BP3. We do actually want decreased IGF-BP1. Okay, So women with high estrogens, they don't get the increase to IGF-BP3 from GH, and they get a much greater increase to IGF-BP1. This results basically in lower IGF-1 dose response. So since women already have, threefold GH greater than men, in accounting for body size, since estrogens do not decrease GHRH and GHRP synergy, it's just more effective and economical for women to use these GH secretagogues than RhGH. Basically, estrogen is beneficial for the drive that these secretagogues push the hypothalamus and pituitary to secrete. Estrogen enhances it. Men, we get a lot more out of driving our GH up, but women, they already have high GH, so they benefit more from these secretagogues. All right, so let's talk about the fourth and final section, which will be thyroid function a la AAS and RhGH. This is a topic that I did delve into in my July newsletter. So for those of you that aren't already subscribed to that, I do suggest going to my website, ampule2.com, and clicking sign up for Type-IIx's newsletter so that you can start receiving these. I do have in the Discord channel of mine a articles channel and a Dropbox channel that you can find past issues from, but I would suggest signing up for that newsletter so you get them up to date. Email. All right, so let's talk about the hormonal effects on thyroid function of AAS and RhGH. So androgens and GH dysregulate thyroid function per se. Androgens decrease TBG, or thyroxine binding globulin. In so doing, they decrease total T4, which is the prodrug to T3, which is the active thyroid hormone, and serum, which is our free circulating blood. And it increases resin uptake, or local cellular tissue level uptake of T3 and T4, which exerts a pull on the blood, thereby reducing them in free circulation. Doing more with less. RhGH increases peripheral local cellular tissue level conversion of T4 to T3, thereby increasing T3 bioavailability to cells and tissues, disentangling it from blood levels altogether. So when you see blood work with low T4, it's fine because what's happening is doing more with less. Again, this is what these hormones do to thyroid function. So with TBG decrease that AAS induce, right, it decreased it resulting in decreased total T4 serum levels and increased resin uptake of T3 and T4. This TBG actually corresponds with the anabolic potency of drugs. So basically, weaker androgens don't suppress TBG as much as stronger androgens. It's an interesting correlation, and it's very, very strong. It's like a linear correlation. So like Primobolan, in an equimolar comparison, basically shows that TBG is reduced, but not as potently as like Dianabol, right? So Dianabol suppresses it much more rapidly. Okay, let's talk now about RhGH effects on thyroid function. So with RhGH use, you guys should be monitoring your serum T4. And I would recommend that if you're using RhGH long-term, you do this like maybe every 6 months. Okay, just monitor your T4 levels. The reason you do this is RhGH does not cause hypothyroidism, but it can reveal it. Okay, so serum-free T4, FT4, and reverse T3, RT3 levels decrease, and serum T3 levels increase during long-term GH replacement, like greater than 6 months. The largest change in serum thyroid hormones during GH replacement and long-term use was an increase in serum T3. It decreased reverse T3 and free T4. Decreased serum T4 during long-term GH administration is independent of TSH secretion. And the mechanism for this phenomenon is basically increased peripheral conversion of T4 to T3. So that basically means that in the tissues, more T3 is being converted, right, from T4, meaning that the active thyroid hormone is in much higher activity actually in tissues. So with the therapeutic use of RhGH, like I mentioned, it does not cause hypothyroidism. So in order to distinguish hypothyroidism from GH effects, right, a lot of them have overlap. What you would look for while you're running GH, okay, with respect to detecting hypothyroidism, would be if you were to experience dry and scaly skin, sensitivity to cold, brittle hair and nails, slow movements and thoughts, and depression. As well, if you're not using clem, muscle cramps are an additional symptom that would indicate that you're hypothyroid. The others are just too easily confused with the primary effects of GH and or AAS. All right, guys. So that basically sums it up. I hope you guys enjoyed this podcast. Give it a subscribe to my channel, like this episode, and share it around. I want people to start listening to this more. All right, guys. Thanks a lot. Have a good one.